Hi, welcome back to IU Radiology Case of the Day. My name is Nick Kuntz, and I'm a neuroradiologist at Indiana University School of Medicine, and I'm back with another interesting spine imaging case of the day. As always, all of the educational content found as part of this presentation has been completely de-identified in order to protect patient privacy. Okay, so here's the history for this case. This is a middle-aged woman who presented with lower extremity weakness and pain. And this presented fairly rapidly, sort of crescendoed over several days, maybe to a few weeks in time. But again, middle-aged woman, lower extremity weakness and pain. Okay, so I have 4 images to look at. The image on the left is a sagittal stir image involving the cervical and thoracic cord. The second from the left is the sagittal T1 post-contrast fat-saturated image that corresponds with those levels. The second from the right is an axial T2 weighted image through the upper thoracic cord, sort of at the cervicothoracic junction. And then the image on the far right is another axial T2 weighted image, this time a bit higher up at the C1, C2 level. So keep in mind that clinical history: middle-aged woman, pain, lower extremity weakness. Look at these 4 images, try to figure out what's going on here. What's your differential diagnosis? And what's your top diagnosis here? Okay, so let's take a look at the imaging. First up is that sagittal stir image, and what we can see is extensive central cord signal abnormality throughout most of the cervical levels and all of the imaged upper thoracic levels, as denoted here by the yellow arrows. And this is T2 or stir bright. And importantly, one thing to notice is this involves more than 3 continuous vertebral segments. This is very long segment abnormality. And if you look at the cord thickness, it's only very mildly expanded. It's certainly a little bit more plump than we'd like to see, but it isn't markedly expanded. One post-contrast fat-saturated sequence, we can see that there's abnormal cord enhancement, denoted here by the yellow arrows. This is a bit patchy, it's segmental, and it involves the dorsal cord for the most part. As we look at that axial T2 slice through the sort of cervicothoracic cord, we can again see this cord signal abnormality denoted here by the yellow arrow. And when you look at this, it predominantly involves the central gray matter, predominantly. But there's also some dorsal column involvement that we can see with this yellow arrow. Maybe slightly less than the central, but definitely involving the dorsal cord as well. So when you put this together, all these findings that we have here on the different sequences, what do you call that imaging pattern? This is referred to as a longitudinally extensive transverse myelitis pattern, or LETM. And I want to stress, this is sort of a wastebasket term. It's a helpful imaging pattern to know about, but realize this is not a discrete pathologic entity. This patient doesn't have the diagnosis of longitudinally extensive transverse myelitis. Rather, this is something that refers to florid spinal cord inflammation, and by definition, this abnormal cord signal needs to involve 3 or more continuous vertebral segments. Now, classically, this has been associated with neuromyelitis optica, or NMO, but there's a lot of different etiologies that can have this pattern. So I like to look at this as sort of an entry point for ushering you into a specific differential diagnosis pattern, but it's not a specific diagnosis itself. When you see this, you need to be thinking about multiple potential differential diagnoses. And we can see those listed here. So these are broad categories, and that's the way I like to approach these. You can really get into the weeds if you're not careful with these cases. I like to think of these more in terms of global differential diagnoses, maybe throw out some of the more specific entities, particularly as you dig into the electronic medical record or if you uncover other imaging findings that help you out. But sort of the main players that we're thinking about are rheumatologic, inflammatory, metabolic, neoplastic or perineoplastic, infectious or parainfectious, vascular, and idiopathic. And as you can see, each of these has a handful of things underneath it that can cause this pattern. Certainly, this is not a comprehensive list. These just happen to be some of the major players. But when we look at rheumatologic, we're thinking about things like NMO or NMO spectrum disorder, Sjögren syndrome, lupus, antiphospholipid syndrome. Sort of under the inflammatory category, think about things like multiple sclerosis. It's kind of an odd diagnosis. Maybe it's not entirely an inflammatory disorder, but it does have inflammatory components, particularly within the acute or recent demyelinating event kind of time frame. Closely associated with that is ADEM. You can see it in the setting of Behçet disease, as well as post-radiation changes. In terms of metabolic deficiencies that can cause this, the ones to be thinking about would include B12 and copper deficiency. This may represent an underlying paraneoplastic syndrome as well. Certainly you want to be thinking about are we harboring a cord tumor underlying all of this? However, in this case, we didn't really see much in the way of cord expansion. The enhancement was a bit patchy, and it didn't really look great for a tumor. Viral etiologies are probably an under-recognized entity that can cause this, and interestingly, there's been more research looking at some of these specific viruses like HTLV1 that tends to be a common offender and may in fact have some overlap with the rheumatologic causes of this. But be thinking about things like HIV, HTLV1, Epstein-Barr, cytomegalovirus, and varicella zoster. It's been reported in the setting of syphilis and tuberculosis, as well as some parasitic infections as well. I haven't particularly seen any of those, but I have seen a few cases of viral etiologies causing this. Certainly be thinking about vascular etiologies whenever you have segmental signal abnormality. Could be a cord infarction, although this is awfully large. But be thinking about cord infarction when you see segmental long segment abnormality, as well as dural AV fistula. In this case, we don't see the telltale flow voids. And vasculitis is definitely something to think about in these cases as well. And then sometimes it ends up just being idiopathic, in which aquaporin 4 is negative, and they may not know exactly what's causing it. These longitudinally extensive transverse myelitis patterns, well, I think it's always a challenge. One of the problems is, as you saw on that last slide, the differential diagnoses are incredibly broad, and in my experience, I think it's virtually impossible to be highly specific with your diagnosis on imaging alone in most cases. This case, however, we were able to come to a very specific diagnosis based on some coroner findings. So I think things that can be helpful are to dig into the electronic medical record, try to figure out what's going on clinically with the patient. The referring team may very well have a very good idea of what's going on before the patient ever hits the MR scanner based upon serology, clinical presentation, that sort of thing. And I want to stress, and that's the reason I'm showing this case, it's really helpful to be looking outside of the spine. Look for those so-called corner findings that may grant more specificity to your differential diagnosis. Okay, so let's look at that last image. It's an axial T2 weighted image at the C1, C2 level. And if you look outside of the spine, you'll see that the parotid glands are abnormal in appearance. They have marked fatty replacement. They're very T2 hyperintense. If I were to show a T1, they'd be T1 hyperintense as well. But look carefully within the parotid glands, and you can see they have a microcystic or micronodular appearance. So put it all together. What's your top diagnosis in this case? The diagnosis we suggested as this patient was scanned in the ER and was confirmed later by serology. Okay, this is a case of Sjögren syndrome myelopathy, or SSM. Now, in patients who have Sjögren syndrome and they have CNS involvement, spinal involvement is seen in about a third of those cases. So most of the time you'll get brain involvement, but about a third of the time of patients who have true CNS involvement, you'll see spine involvement. And that may even, in fact, be the initial manifestation of their Sjögren's. It sort of has a variable course when it involves the spine like this. About 40% of the time they'll have an acute myelitis like this patient had. And about half of these patients, maybe slightly greater than half, will go on to develop a chronic myelopathy as a result. Now, interestingly, this is associated with NMO. About 10% of NMO patients also have anti-SSA or anti-SSB autoantibodies, which are the antibodies specific to Sjögren syndrome. So there is sort of an incompletely understood overlap of some of these diagnoses. Fortunately, these tend to be steroid responsive, so it's important to make this diagnosis and make this diagnosis accurately and expeditiously as possible so these patients can get started on high-dose steroids. So here's a nice paper. It's a bit old. It's about 10 years old at this point, but I think it's worth taking a look at for all the residents and fellows out there. And this sort of details some of those associations of Sjögren syndrome myelopathy and neuromyelitis optica. Incompletely understood, but just keep in mind there is some association between these two entities. So if you're thinking of one, always keep in the back of your mind, could it also be the other? Okay, let's wrap this up. So this was a case of Sjögren syndrome myelopathy. The key imaging features in this case would be to recognize that longitudinally extensive transverse myelitis pattern. Important by definition, this involves 3 or more continuous vertebral segments. And you will have cord edema or cord signal abnormality, as well as potential enhancement like this case showed. In this case also, an important feature was to recognize the abnormal appearance of the parotid glands with that microcystic or micronodular appearance and phatic replacement, very typical of Sjögren syndrome. A couple pitfalls to keep in mind. As I said before, I'll stress it again, longitudinally extensive transverse myelitis, it's an important imaging pattern, but it is not a specific diagnosis. Whenever you see this pattern, you want to be thinking about as well as reporting a broad differential diagnosis to your referring docs, and that would include the broad categories of rheumatologic disease, inflammatory disease, metabolic derangements, neoplastic and perineoplastic, as well as infectious, perinfectious, vascular, and idiopathic etiologies for this pattern. And I think it's really incumbent upon the interpreting radiologist to dig into the medical record, as well as to think and to look outside of the spine for those helpful hints that may help you narrow down your differential diagnosis and give something that's more specific to that patient's presentation. Joining in and following along with IU Radiology Case of the Day, you can follow along on Twitter at @NAKuntz, and I would invite you to check out our complete collection of Radiology Case of the Day materials that can be found at radtf.iuhealth.org/COTD. Thanks so much.